afternoon, everyone. My name is Anil Vachani. I'm a pulmonologist at the University of Pennsylvania. Thank you for the invitation. In the next 15 or so minutes, I'm going to try and give an overview of malignant diseases, detection, and treatment. Because of the time limitation, I'm going to really limit my discussion to mesothelioma and lung cancer. Just briefly, as we all know, mesothelioma most commonly occurs in the pleural space, in the thorax, but can also occur around the lining of the heart, the pericardium, or the pericardial space, the peritoneum, or the lining of the abdomen, or around the tunica vaginalis, the testes. But pleural mesothelioma accounts for about 80% of these cases. Now, lung cancer, there's two main subtypes, non-small cell lung cancer and small cell lung cancer. 80% of lung cancer is related to non-small cell disease, and that's the one that's probably most likely asbestos-related, as opposed to small cell. So in the interest of time, I'm going to focus on pleural mesothelioma and non-small cell lung cancer for the remainder of this talk. Just a very quick overview of what the general approach is for detection and treatment. As Dr. Miller discussed already, there's clearly a lot of interest in early screening methods for both of these diseases, though as yet there are no approved screening methods for either lung cancer or mesothelioma. Clearly, low-dose spiral CT scan is very, very promising, I think, for both of these diseases. And I think that it should be considered on a patient-by-patient basis at this point for our practices, and we do screen in a certain number of cases. However, I don't think widespread screening in the United States will take off until we have results from the NIH National Lung Screening Trial, and there are some screening trials that are ongoing for mesothelioma as well. The main studies that need to be done to establish a diagnosis of either one of these diseases in a patient are twofold. One is to get good imaging studies of the chest, and as Dr. Harbert mentioned, we use CAT scans of the chest at this point, usually a high-resolution CT scan, and ultimately a biopsy, and I'll go into further detail on which biopsy is appropriate in which situation in just a moment. And the next major step is to establish the stage of disease for either one of these tumors, and that's most commonly done with 3 studies nowadays. One is a PET scan, and it probably has a very good role in lung cancer, and it should be done for every non-small cell lung cancer patient at this point. And it certainly is gaining evidence in mesothelioma as well to establish the presence of distant disease in patients with mesothelioma and to determine whether they have metastatic disease that has gone outside the chest. Finally, an MRI of the brain is probably standard for both of these diseases as well. One major issue that comes up is to establish whether the tumor, either non-small cell lung cancer or mesothelioma, has spread to any lymph nodes, and particularly lymph nodes in the center of the chest, or what's called the mediastinum, and there is a surgical procedure called mediastinoscopy, which I'll also describe in just a few minutes. Just to start with some very brief normal anatomy, and I apologize for some of those in the audience who know this very well, but this is just a cartoon of the chest. This is the windpipe, the right lung, the left lung. And as you can see, the pleural layer is twofold. There's a visceral pleural layer, which sits right on top of the lung, and a parietal pleural layer, which sits along the chest cavity. Those two pleural layers create a potential space called the pleural space, which is where mesothelioma tends to develop. This can also sort of be seen in cross-section here with the right lung, left lung, and the pleural space surrounding both of those lungs, and in cross-section here with the lung on either side, the heart in the middle, and the purple line is to demonstrate where the pleural space would be, but really, when the pleural space is normal, you can barely see it on a cross-sectional CT scan. This is what a normal chest x-ray looks like in most patients. Again, a lot of black space because air doesn't develop an image on an x-ray, and so it comes up as black. The heart sitting in the middle, the spine and the windpipe coming down the center, the diaphragms on both sides. And an important thing to note is that there should always be a sharp reflection of where the diaphragm meets the chest wall along here. And that'll come important in just a second. This is how mesothelioma develops. Mesothelioma develops inside the pleural space, inside the reflection between the two pleural surfaces, and really grows along the diaphragm and along the chest wall, and then it can slowly begin invading into the lung. When you look at it on a chest x-ray, it most commonly presents in one of 2 ways. Either this way, with a very, very small amount of blunting of this angle, which means that there's fluid and tumor developing down in that angle, or with a large amount of fluid and a large amount of tumor that's very obvious on a chest x-ray. But it's clearly these sorts of patients that often get missed initially, where the diagnosis is suspected, but no workup is initiated. The patients remain often asymptomatic, and this can linger for many, many years prior to a diagnosis being established. The most common diagnostic procedure that should be performed in the setting of a pleural effusion based on those 2 prior x-rays is something called a thoracentesis. This is a very simple procedure. It can be done on an outpatient basis. It's done by taking a syringe with a needle and really going through between two ribs in the back into the pleural space and aspirating that fluid into a bottle and examining that fluid under a microscope. And what you should see, ideally, are normal cells. These very small cells are normal white blood cells that are present on a cytological examination. When you see these large, dark staining, large nucleus cells, that's indicative of cancer. And various stains can be used to determine whether that malignancy is mesothelioma or non-small cell lung cancer or any other malignancy in that space as well. If for whatever reason a thoracentesis is performed but no diagnosis is established, many patients with mesothelioma are often required to go to thoracoscopy to establish the diagnosis. Thoracoscopy is a surgical procedure. It's often also called video thoracoscopy, VATS. What this procedure allows one to do is to use a videoscope. So there is a camera, and then two surgical tools are inserted between the rib spaces. The lung is deflated, and a little piece of a lung biopsy is taken from an abnormal appearing area. This is actually a very, very commonly used way to establish the diagnosis in both lung cancer and mesothelioma. So what you see when a thoracoscopy is performed, what I'm looking at now is we're using the videoscope inside the pleural space, and we're looking onto the surface of the lung. And what you can see is a couple of white nodules here. And this is what mesothelioma looks like in some of its earliest phases. It really just develops nodules on the pleural surface. These can slowly grow and coalesce and really form larger tumor masses, and I'll show some pictures of that again in a moment. So very quickly on treatment for mesothelioma. I think there are two major goals. One is to relieve symptoms, and I think palliation has to be a major, major focus in mesothelioma treatment. And that can be done in many ways, but the most common thing that causes symptoms in mesothelioma is the large accumulation of fluid, as I showed on that X-ray previously, which causes patients to have chest pain, shortness of breath, can irritate the lung lining and cause a cough as well. And so one of the major things that we perform is a drainage procedure of the fluid. And this can be done either at the time of surgery, when they're having the thoracoscopy, all that fluid can be drained out, and those pleural surfaces can be fused to make sure that the fluid does not accumulate again in the future. Or you can use catheters that can be placed into that pleural space, and the catheters can be used to drain that fluid over a period of time, over a period of months, as the patient is undergoing treatment. The other thing that often occurs is as the tumor is growing inside the chest space, it can start to invade the chest wall. And that's a very, very painful thing for patients with mesothelioma because the chest wall is lined with a number of nerves that run along where the ribs run. And so the major treatment for that, at least currently, is either to use radiation directly to spaces that are affected for palliation of that pain and to use pain control medicines. So I put this at the very top of the list because I think that this is the thing that is often ignored when we talk about treatment for mesothelioma, but palliation and pain control really should be the major focus. Now there clearly are, treatment for mesothelioma is very challenging. We clearly have not made major strides in improving survival in mesothelioma over the last 20 or 30 years. There have, however, been a few somewhat modest developments in mesothelioma care which I will review. One is chemotherapy. There has recently been a study performed, a large randomized phase 3 study, which has shown that chemotherapy with a couple of specific drugs can improve survival, though modestly, in mesothelioma. And I think at this point, all patients with mesothelioma should at least be seen by an oncologist to discuss their options for chemotherapy, and this should not be avoided or ignored in patients with mesothelioma as has been done in the past. And the second major advance has really been the use of surgery in a subset of patients. Unfortunately, most patients with mesothelioma present at a time when their disease is fairly advanced and when they are fairly ill, and so they're often not eligible for major thoracic and chest procedures. However, there is some evidence that surgical procedures may be useful when combined with other treatments. And the three major treatment types are debulking surgery, where you simply go in and try and resect out as much of the tumor mass as possible. Pleurectomy, where you go in and try and resect out all of the pleura just by peeling it off the lung and taking it out. Or a procedure called extrapleural pneumonectomy. This is a procedure where a surgeon goes into the hemithorax, the chest that's affected, and the entire lung and the pleural surface and usually the diaphragm are all taken out together. And the goal of this is to really remove all the tumor burden in that patient and to try and achieve some degree of cure or at least prolongation of survival. I know we don't want to show many pictures, but I'm just going to show what extrapleural pneumonectomy looks like. So as you can see, this is an entire all the tissue in a chest being removed. And in cross-section, you can see that the pleura, which is lined with the mesothelioma tumor, the entire lung, and the diaphragm are all removed. This tends to be a difficult procedure to tolerate, and so patients should really be evaluated very carefully by specialized centers to see if they're eligible or appropriate for this procedure. There are clearly some exciting areas that are ongoing in mesothelioma research, and I'll mention them very briefly. There are many trials ongoing of new experimental therapies, chemotherapies, newer oral chemotherapies, which are easier to tolerate, can be taken at home without needing to be in an oncologist's office. New treatments for immunotherapy, gene therapy, and photodynamic therapy, which I won't go into in the interest of time. And lastly, I'll mention that there is a new blood test available for disease monitoring, which is available in the United States and in Europe and in Australia. It's called Mesomark. I think the role of this blood test is still being fully determined based on studies, but it is approved by the FDA now in the United States as well, and it should be considered for patients with mesothelioma. I actually think that the blood test probably has a larger role in diagnostics and potentially in screening, though clearly it has not been studied well enough for those indications and is not yet approved for those indications. So let me briefly turn to lung cancer in my last couple of minutes and just show a few pictures and go over a few procedures. This is the most common way a lung cancer presents. A patient who's asymptomatic or has some nonspecific symptoms gets a chest x-ray and has an abnormal shadow. This little round shadow here shouldn't be there, and that's often the first sign of a lung cancer. The diagnosis of non-small cell lung cancer, again, is very similar to mesothelioma. Everyone should have a CAT scan, and everyone should have some sort of biopsy procedure. And the biopsy procedures in non-small cell lung cancer most commonly is done either through a bronchoscopy, and that's diagrammed here, where a flexible scope is inserted through the mouth or the nose into the lungs, and the abnormal area is visualized and biopsied. You can also do it through needle biopsies done directly through the chest wall, or you can also have it done through a thoracoscopy, the picture I showed earlier in the talk. Similarly, all lung cancer patients should have staging tests done, including a PET scan and an MRI of the brain. For those patients where we need to establish whether their lymph nodes are involved, there's a procedure called the mediastinoscopy, and I wanted to briefly describe that here. It's a surgical procedure done under general anesthesia, but is commonly performed in patients with lung cancer or mesothelioma. It involves a scope being inserted really through an incision just below where your sternal notch is, your little right below here in the neck. And it's usually a 1 to 2 centimeter incision, and a scope can be inserted, and all of these lymph nodes that sit along the windpipe and at the root of the lung can be visualized and biopsied. Again, often performed in patients with these two diseases. Lastly, I'll say that staging is critically important in non-small cell lung cancer because it really determines your prognosis and what treatments you'll be eligible for. So what we do now is to look at the primary tumor, look at the lymph nodes, and use the PET scan to see if there's any distant sites of tumor involvement. What I'm trying to show on this diagram is what is a scheme from early to late stage disease. So when a nodule is present just in the lung, surrounded completely by lung and doesn't involve any other spaces, it's an early stage, stage 1 tumor. As it starts to invade into lymph nodes or into the chest wall, it's later stage, stages 2 and 3. And when it spreads to other parts of the body outside the chest, it's stage 4. And that's very important because it determines whether you can ultimately have surgery for your disease if you have early stage disease, stage 1 and 2, and potentially for stage 3 patients, or whether you're really going to be treated with chemotherapy and radiation. Surgical resection, as I mentioned, is limited to people with early stage disease, those who have good pulmonary function, so everyone should get pulmonary function tests, and those who have good performance status are able to get up and walk around, or those patients who are not bedridden. So just some very few quick conclusions. I think even though screening is not yet approved by many insurers and by Medicare, it's certainly important to have all symptomatic patients evaluated quickly with the full spectrum of tests that I've described when appropriate. I think the diagnosis of mesothelioma can often require surgery because it's very difficult to diagnose just based on the thoracentesis procedure and the evaluation of pleural fluid. And so many of these patients often are required to go through a surgical procedure. I think therapy in mesothelioma is coming along to the point that therapy should be individualized based on each individual case. If it's limited, the patient's healthy, they should certainly see a thoracic surgeon at a specialized center and be considered for a surgical procedure. If not, they should certainly see an oncologist and be considered for chemotherapy or for a clinical trial. And certainly all early lung cancer patients, early stage lung cancer patients should be considered for surgical resection because that is the only way to achieve a cure in that disease. Thank you for your time.